Good evening, all. Welcome all to the today's class. We have session today on myocardial infarction and pregnancy. This is from the maternal medicine module, and this module is important from EMQ point of view because many questions are asked from the cardiovascular system and pregnancy. Okay, so the myocardial infarction is rare, but it is a life-threatening condition. As compared to the non-pregnant status, there is increased risk of myocardial infarction during pregnancy, almost 3 to 4 times there is increased risk, and this high maternal mortality is there if we miss the diagnosis. So it requires early diagnosis and multidisciplinary team management. Up to 50% it occurs in the peripartum period. So most of these myocardial infarctions we will see in the peripartum period, maybe around third trimester and early postpartum. Okay. So as per the UK OSS study, the incidence is less than 1, that is 0.7 per 1 lakh maternities. Maternal death is less than 0.5 per 1 lakh, and risk increase in pregnancy is around 3 to 4 times as compared to the non-pregnant, and most of the cases will happen in the peripartum and the postpartum period. Basically, there are two types of myocardial infarction which can be identified, that is based on the ECG. So one which shows the ST elevation and the one which does not show the ST elevation. So you have non-STMI and STMI, that is because of the partial occlusion, and you can have STMI, okay, where there is a ST elevation, okay, STEMI and non-STEMI. Okay, so STEMI is complete occlusion, non-STEMI is a partial occlusion. However, the pathophysiology is same, but the severity of the presentation will be different in both. Okay, and this is classification is mainly based on the ECG. This pathophysiology is same as that of the non-pregnant state, that there is an endothelial injury, plaque formation, there is a rupture of the plaque, there is a platelet activation leading to the thrombus formation and leading to the finally coronary artery occlusion. So if there is a partial occlusion, it leads to the non-STEMI type of MI, and if it is a complete occlusion, it will lead to the STEMI type of myocardial infarction. So the physiological changes which are happening into the cardiovascular system, they are responsible for this. We know that this early pregnancy, around 6 weeks, there is increase in the plasma volume, and this is mainly because of the activation of the renin, angiotensin, aldosterone system. There is also decrease in the peripheral vascular resistance, and this is because of the decrease in ANP levels and vasodilatation. Circulation, there is hyperdynamic circulation, and myocardial oxygen demand is also increased, and this is mainly because of the increase in the cardiac output. So around mid pregnancy, what happens up to 20 weeks, 25 weeks of gestation, there is increase in the cardiac output. This cardiac output is increased mainly because of the stroke volume. So up to 25 weeks, the cardiac output increases mainly because of this stroke volume increase. However, after 25 weeks of gestation, the cardiac output is increased further because of the increase in the heart rate. So initially there is a stroke volume increase, later on the heart rate also increases, the cardiac output continues to increase. Okay, so blood volume is increased around 140 to 150%, and the peak is around 32 weeks of gestation. Okay, so these minor things can be asked as a SBA also. During labor, there is increase in the heart rate, blood pressure, cardiac output, all are increased. And during labor, what happens? There is increase in the cardiac output by around 50%, and there is a uterine autotransfusion because the around 500 ml of blood will be transferred into the systemic circulation. So blood shifts around 300 to 400 ml per contraction into the maternal circulation. During pushing in the second stage, CVP and cardiac output are increased, will show fluctuations, and this is mainly because of the Valsalva maneuver. And in third stage, there is a increase in the blood return around 500 ml from the uterus. The preload is increased, that leads to the sudden increase in the volume load, and cardiac output and CVP are increased, leading to risk in cardiac disease. So postpartum, then these changes will start reverting back. It will start somewhere in the first 48 hours, but it will continue, and it will take around 4 to 12 weeks for all these changes to become normal. Okay. So another change is that there is a reduced oxygen supply, and this is mainly because of the physiological anemia. There is a decreased diastolic blood pressure, and that is why there is a decreased coronary perfusion also. And pregnancy, we know that it is a hypercoagulable state. So there is increase in levels of factor 2, factor 8, factor 7, and factor 10. So 2, 7, 8, and 10, these factors are increased. then increase in the von Willebrand factor is there. Protein S levels are decreased, and also plasminogen activator inhibitor levels are increased. So that increases the thrombosis risk. So these are the changes which are happening. So here you certain SBAs, especially the factors which are increased, that you should know. What happens to the factor 2, factor 8, factor 7, factor 10, they are increased. Factor 9, there is no change. Okay. There is increase in the von Willebrand's factor normally. Okay, so these are the changes. So these minor things can be asked in the SBA also. Okay, so what happens basically in the peripartum period? This peripartum period is at risk mainly because of the increase in the preload. There is auto transfusion of around 500 ml post delivery. There is increase in the cardiac output. Normally, what happens during pregnancy, the uterus compresses on the IVC, but in the postpartum period, there is a decompression of the IVC that leads to the increase in the venous return, and there is increased shear stress leading to coronary dissection risk. Okay, so not only that, it is also peak period for the hypercoagulability. So we should remember that during peripartum period, there is a highest risk period for myocardial infarction and plus coronary dissection. Okay, so coronary dissection is also very, very important etiology for myocardial infarction in pregnancy. So these changes we have seen what happens during the pregnancy. Hematological changes also we have discussed. So what is the presentation? So key take home message that chest pain in pregnant and postpartum women, we need to investigate. The risk factors will be diabetes, smoking, and increased maternal age. Occurring during labor and postpartum. So peripartum period is most important, and sudden cardiovascular collapse can be the presentation. So one of the differential diagnosis, if there is a scenario which is related to sudden cardiovascular collapse, please look into the risk factors for the cardiovascular conditions and look into the investigations which are given to you. Okay, so what are the important associations? It most commonly it is associated with atherosclerosis. That is the commonest one. Okay, another is a coronary artery thrombosis, and another is a coronary artery dissection. So that is increase in the peripartum period. So this coronary artery dissection is important during the pregnancy. The commonest cause is atherosclerosis, that is common in pregnancy as well as non-pregnant, but coronary artery dissection is more common during the pregnancy period itself. So if you see this TOG, what does exactly it mentions, because this is a SBA question. Okay, they'll give you these options as atherosclerosis, thrombosis, coronary artery dissection, etc., etc. So the causes are divided into atherosclerotic, often with cardiovascular risk factors. So the cardiovascular risk factors such as age of the patient, diabetes, hypertension, etc. And these patients will have atherosclerosis. While non-atherosclerotic, which include the coronary artery dissection, thrombosis, and coronary artery spasm. Okay, so these are non-atherosclerotic causes. Then, as per the UK OSS study, the coronary atheroma is seen in 50% of patients. The coronary artery dissection is in 22% of patients, and coronary artery thrombosis in 14%, and only 2 women 14%. Okay, so if you see that, then coronary atheroma is around 50% of cases, and dissection is seen in 22%. If you see the general population of pregnant women with myocardial infarction, then the atherosclerosis is going to be common. Okay, but if you see the patients who does not have atherosclerotic factors, or those who are not high risk for the atherosclerosis, in them coronary artery dissection is going to be the common. So coronary artery dissection must be considered as a cause of a acute MI in a pregnant women with no cardiovascular risk. So if the scenario mentions that there are no cardiovascular risk factors, then only the coronary artery dissection, but overall the atheroma is the common cause for the myocardial infarction. I hope this concept is clear to you. Okay, so what is the clinical strategy? We need to keep in mind about the myocardial infarction when there is unexplained chest pain, breathlessness, hemodynamic instability. Okay, so do not miss, because symptoms may mimic normal pregnancy discomfort, because presentation we may consider this as a normal pregnancy discomfort also. Management is always multidisciplinary management, and the team will include obstetricians, cardiologists, anesthesiologist, and obstetric physician. Okay, so there are certain risk factors. The risk factors will be obstetric as well as non-obstetric risk factors. So higher parity, maternal age more than 35, pre-existing hypertension, pre-existing diabetes, pre-existing IHD, smoking, obesity, and strong family history. These are the high risk factors. Okay, so the same factors are given in this particular table, and other risk factors are hyperlipidemia, preeclampsia, eclampsia, thrombophilia, migraine headache, postpartum infections, and blood transfusions. So these are the apart from the risk factors which we have discussed. Okay. So from an examination point of view, the commonest time is a late pregnancy for myocardial infarction. Delivery within 2 weeks of infarction, that has got the highest maternal mortality. So if the delivery happens within 2 weeks of the myocardial infarction, there is a highest maternal mortality. Okay, so generally it is better to postpone the delivery by 2 to 3 weeks. This is one of the principle which we should remember. Okay, so main causes of acute myocardial infarction in the pregnancy, it is a coronary atherosclerosis. Okay, that is common overall, and non-atherosclerotic causes, among that the common will be the coronary artery dissection, then coronary artery thrombosis, and coronary artery spasm. Then it could be drug induced like terbutaline, ergotamine, bromocriptine, and cocaine. These are drug induced spasms. Okay. Additional things which you should remember, that there is a 30 times risk if the maternal age is more than 40 years for myocardial infarction as compared to the young patient who is around 20 years. So 30 times there is increased risk of myocardial infarction. Obesity is very significant contributing factors, and it is seen in around 64% of maternal deaths because of the myocardial infarction. During pregnancy, HDL, which is a protective cholesterol, that level is decreased. So multiparity has got multiparity association is not very clear, but it may be because of the co-founded by the age. Okay, migraine suggests vasospastic mechanism. Then what are the causes? Uh, we have seen atheroma is seen in 50% of cases, and dissection is seen in 22% of patients. Okay. So this we have already discussed. So coming to the coronary artery dissection, it occurs without any risk factors. So if the patient does not have risk factors for atherosclerosis, coronary artery dissection still can happen during the pregnancy. Peak is in the third trimester and up to 3 months postpartum. Left and anterior descending is the most commonly involved in around 80% of cases, and mortality is around 30 to 40% of patients. Okay. So it is generally the hormonally mediated, and it is the increased levels of progesterone, protease activity is increased, and decreased prostacyclin levels. Okay. So these are the factors which are responsible for the coronary artery dissection. Then coronary thrombosis, which accounts for 8 to 14% of cases, and this is mainly because of the hypercoagulable state, hereditary thrombophilia, etc. Okay, coronary spasm, it may be because of the drug, or it may be because of the increased sensitivity to angiotensin 2 and noradrenaline. Okay, it may be because of the endothelial dysfunction also. And other causes which are rare are the vasculitis like Kawasaki disease, collagen vascular disease, etc. They are not that common. Coming to the ECG changes. Okay, ECG changes which are very specific to the myocardial infarction, that is ST elevation. That is the most sensitive early marker. Okay. Another is ST depression, then symmetrical T wave inversion, and presence of new Q waves. Okay, you will get ST elevation, ST depression. There will be symmetrical T wave inversion and new Q waves. Okay, so these are acute MI related changes, and there are certain changes which are physiologically seen. So normal variation in the pregnancy can also be there. These are the ECG changes which are just the variation seen in normal pregnancy, and that is why there can be dilemma in pregnancy, and hence the sensitivity of the ECG is only 50%. Okay, so please remember the sensitivity of the ECG for diagnosis of myocardial infarction is only 50%. Okay, but still it is a first line. Okay, and the specific findings are ST elevation, ST depression, symmetrical T wave inversion, and newly developed Q waves. Okay, now what are the normal variation in pregnancy which are seen in ECG? That is 15 to 20-degree left axis deviation, then ST segment depression, T inversion in inferior and lateral leads, small Q wave and inverted T wave in lead 3, and Q wave in the lead AVF, and inverted T wave in V1, V2, and occasionally in the V3. So T wave inversion is seen symmetrically in acute MI also, and T wave inversion is also seen in various leads, even as a normal variation during the pregnancy. And that is why there may be dilemma in interpreting the ECG in pregnant women. Okay. So normal ECG variations, these are the variations which we have discussed. Then ST elevation is the most specific for acute myocardial infarction. Normal pregnancy ECG can mimic ischemia, and that will create a diagnostic confusion. So diagnosis of myocardial infarction in pregnancy is mainly clinical, same diagnostic criteria as non-pregnant. Low index of suspicion is the major cause of misdiagnosis. Okay, so high index of suspicion should be there. Symptoms may mimic pregnancy because of epigastric pain, vomiting, dizziness, etc. Okay. Now coming to the investigation, first line is a ECG. It may be normal initially, so serial ECG is essential. Sensitivity is only 50% that I have discussed. Then coming to the biomarkers, both troponin I, troponin T can be performed. That is the investigation of choice. Then normally in pregnancy, it is not elevated. It is not affected by labor, cesarean section, and anesthesia. It peaks at around uh, 12 hours, okay, after the incidence. Okay, so troponin I and troponin T, these are the biomarkers which are preferred. Other biomarkers such as CK, myoglobin, they will increase in labor and they are not reliable. Okay. So this is also SBA regarding the biomarker troponin T and troponin I. They are reliable biomarkers. Okay. Coming to the troponin interpretation, so in preeclampsia and gestational hypertension, there is a mild increase is possible. Pulmonary embolism also troponin levels are increased, but in MI, they are definitely above the diagnostic threshold. Okay, so in myocardial infarction, they are otherwise these levels are mildly increasing even preeclampsia also, but in MI they will be significantly raised. So echocardiography will help to exclude the other differential diagnoses such as aortic dissection. It will assess the left ventricular function, detect the labor wall motion abnormalities, and it is safe in pregnancy. Next is the coronary angiography. It will be diagnostic as well as therapeutic also. It is safe if the radiation exposure is less than 50 milligray, and use radial access and use shielding. Okay, so it need not be delay if it is indicated. So what is the exposure in various procedure for the mother and for the fetus? Okay, so chest radiograph is less than 0.1 for the maternal exposure. Then CT chest 7 milligray, coronary angiography 7 milligray, and percutaneous coronary intervention PCI is 15 milligray for maternal exposure. For fetal, that is still less. So maximum is with percutaneous coronary angiography, that is 3 milligray, and it is very, very less for the fetus in the rest of the investigation. So less than 50 milligray, there is no risk of malformation. Okay. So imaging should not be withheld. Now coming to the management of myocardial infarction, it is same as in non-pregnant status. Goal is a rapid reperfusion. It is managed in ICU, HDU, and along with the multidisciplinary team. So primary PCI, okay, that is the gold standard, percutaneous coronary intervention. Okay, so primary percutaneous coronary intervention (PPCI) is the gold standard of the treatment of myocardial infarction. Okay, so bare metal stent is preferred, thromboprophylaxis if PCI is to be delayed. Okay, the other option is a thrombolysis. A drug which is used is a TPA, does not cross the placenta. Maternal hemorrhage is around 8% risk. If it is a non-STEMI, management will be antiplatelets first line. Then consider angiography if symptoms persist, and hemodynamic instability and high risk features. So non-STEMI is a partial occlusion. So antiplatelets are preferred. If it is a STEMI, the first is will be PPCI. Okay, primary percutaneous coronary intervention. Okay. So drugs in myocardial infarction. So what are the safe drugs? Aspirin in low doses, 60 to 150 milligram is safe. Heparin can be used. Labetalol can be used. Nitrates and clopidogrel. Okay, nitrates, we have to be very cautious, and clopidogrel, if indicated, only for short duration. While heparin does not cross the placenta, can be used. Labetalol is also a beta blocker of choice during pregnancy. Okay. So management, the same drugs we have discussed here, the same chart is given. Okay, what is contraindicated? Statins are contraindicated. Then ACE inhibitors and ARB is contraindicated. Okay. So nifedipine is to be avoided post MI because there is increase in the mortality, and IV nitrate is to be avoided because fetal distress is reported. This also you should keep in mind which drug is to be avoided post MI. Okay, this can be asked in the SBAs also. Okay. Apart from that, there is a risk from the AC inhibitors for the renal dysgenesis, oligohydramnios, pulmonary hypoplasia, FGR, and fetal death. So these are the adverse effects of AC inhibitors. Now coming to the obstetric management. So delivery timing, delay the delivery by 2 to 3 weeks after the myocardial infarction. Highest mortality if the delivery happens within 2 weeks. Okay. General approach, we have to individualize the decision, involve multidisciplinary team, give steroids if there is a risk of the preterm delivery, and continuous maternal fetal monitoring is required. So delivery planning, as such, there are no standard guidelines, but we have to individualize each case. Decision is based on the maternal cardiac status plus the gestational age. MDT planning is essential. Include the neonatologist additionally and deliver in high-risk obstetric units with ICU support. Okay. So vaginal delivery is preferred because it will reduce the blood loss. Also, chances of infection are reduced. VT risk is reduced, and if the patient is stable, vaginal delivery is preferred. If the patient is unstable, or if there is a recent myocardial infarction, then the cesarean section. It avoids hemodynamic stress of the labor. Okay. So no mortality difference. The decision is clinical, and there is no indication for the routine LSCS. Okay. So timing of vaginal delivery will depend upon the Bishop's score, fetal well-being, labor duration. Okay, so these are the factors which we need to take into account. Intrapartum, epidural analgesia. So if you have the option of vaginal delivery with epidural analgesia in a stable patient, that will be the best, because epidural analgesia will reduce the pain, will also reduce the sympathetic stress also. Left lateral position will reduce the IVC compression. Continuous ECG and pulse oximetry is required. Continuous CTG is required for the fetal monitoring, and consider arterial line. Okay. Second stage, we should shorten the second stage by instrumental delivery. Avoid Valsalva, that decreases the hemodynamic stress. Then uterotonics. IV low dose oxytocin, less than 2 units per minute. Slow oxytocin is preferred in myocardial infarction post delivery. It is safe. Ergometry is to be avoided. Okay. Drugs during the labor, nitroglycerin is anti-ischemic, beta blockers are safe, CCBs used cautiously, and nitroglycerin CCBs may prolong labor also because of the tocolytic action. Then postpartum, monitor the patient in HDU ICU for 24 to 48 hours. High risk period is major hemodynamic shifts happen this time, and fluid shifts because of and that will lead to the risk of deterioration. Thromboprophylaxis is important, essential in all cases, and risk assessment we have to do. Okay. So cardiology follow-up GP, this is important from the part 3 MRCOG point of view. Contraception and future pregnancy depends on the cause of MI and left ventricular function. Individual's counseling is required. So screening for these factors, no routine screening for asymptomatic women, no evidence of benefit or cost effectiveness. So practical approach is that identify cluster risk factors at the booking. If more than 3 risk factors are there, and label this as a high cardiovascular risk and lower threshold for investigating symptoms. So if there is any symptom, then definitely we have to investigate and encourage lifestyle changes. Okay. So the incidence is increased because of the increased maternal age, increased obesity, diabetes, hypertension, lifestyle factor. Most women with risk factors will have uneventful pregnancy. So only presence of risk factors will have uneventful pregnancy. However, if there are symptoms, we need to investigate. So low threshold for suspicion, do not delay investigations, early cardiology involvement. MDT improves survival, but may not always be feasible in emergency. Doctor, we have finished the talk article discussion. Thank you. We have questions, doctor. Should we go ahead with the questions? We have one more talk for the discussion. Few questions, doctor.
A 32-year-old primary graver at 30 weeks presents with chest pain. ECG shows T-wave inversion in V1, V3 and in lead 3. She is hemodynamically stable. What is the most appropriate interpretation? Diagnosis of NSTEMI, normal pregnancy-related changes, indicates STEMI, suggests pulmonary embolism, requires immediate thrombolysis. These are normal pregnancy-related changes.
Yes. So this is not a non-STMI because T inversion in V1 to V3. V1 and V2 is more common. Sometimes it is seen in V3 also and in lead 3. So these changes are normal physiological or pregnancy related changes. Okay. So this is normal pregnancy related changes. T inversion in V1 to V3 and lead 3 is normal in pregnancy. So we have to differentiate it from ischemia. Next.
A pregnant woman presents with acute severe chest pain. Which ECG finding is most specific for acute MI? So this is CST elevation is a most
Yes.
specific finding.
Yeah, this is the record. Yes. ST evaluation is more sensitive and specific early marker appears within minutes of onset. Yes, go ahead.
A 28-year-old woman at 36 weeks presents with chest pain. ECG is normal. Troponin is negative at presentation. What is the next best step? So I think it should be B, repeat troponin after 12 hours.
Yes, immediately it may be normal, but after 12 hours, we have to repeat this. Okay, repeat troponin after 12 hours. Troponin peaks at 12 hours. So early result does not exclude myocardial infarction. Next.
A pregnant woman with suspected MI requires coronary angiography. The obstetric team is concerned about fetal radiation. What is the correct advice? So here the answer is C, safe if the radiation is less than 50 milligauss.
Correct. Correct. So safe if the radiation is less than 50 milligray, no increased fetal risk, angiography should not be delayed. Next.
Yes. A 34-year-old woman at 28 weeks presents with STEMI. Percutaneous angiography is available within 60 minutes. What is the best management? So here, A, thrombolysis.
See, it is a primary PCI. PPCI is the gold standard in STEMI, preferred over the thrombolysis if available.
A
Next.
pregnant woman with MI is being treated. Which drug is contraindicated? So in this, the D ACE inhibitors are contraindicated.
Yes, AC inhibitors are contraindicated. Okay. Next.
A woman with recent MI is in labor. Which is the most appropriate strategy? A. Encourage pushing to shorten labor. Avoid analgesia. C. I think this is epidural analgesia.
Yes, epidural anesthesia is safe because it will reduce the sympathetic
Reduce the
response also. Avoid
sympathetic
Valsalva,
drive.
supine position, and ergometry. Next.
Yes. Woman with MI undergoes vaginal delivery. What is the best approach in second stage? So here, prolonged pushing is not advised. Instrumental delivery to cut short the second stage.
Yes,
This should be the
instrumental
answer.
delivery. Yes. Next.
A woman has an MI at 36 weeks gestation and is hemodynamically stable. What is the best plan regarding delivery? So she has MI, so we should delay the delivery for 2 to 3 weeks
Yes, this
to
was a
reduce the
long
mortality.
scenario. Yeah, this was long scenario. I think somewhere in 22, similar kind of question was there, but it was a scenario based long scenario. Okay.
It should be two
Next.
weeks at least.
Yes.
Following vaginal delivery in a woman with MI, which ketotonic is contraindicated. So here D ergometrin is contraindicated.
Yes. Ergometrin is contraindicated. So take home message that pregnancy is a prothrombotic plus high cardiac demand state. Peripartum period is a peak period for myocardial infarction. Non-STEMI versus STEMI it will depend upon the degree of occlusion. Coronary dissection is more common in pregnancy. Always maintain low threshold for diagnosis. Most common cause is atherosclerosis. Most important pregnancy specific cause is dissection. Most dangerous period is a peripartum. Think myocardial infarction even without risk factors. Consider dissection, coronary dissection and spasm. If there are no risk factors, Drug triggers are terbutaline, ergometrin, and bromocriptine. Estivulation is most specific ECG finding. Troponin is a diagnostic test of choice. Normal ECG does not exclude MI. PCI is preferred over thrombolysis. Imaging is safe and do not delay. Delay delivery 2 to 3 weeks post MI. AC inhibitors are contraindicated. Individualized delivery plan. Vaginal delivery is preferred if stable. Epidural plus second stage shortage, that is done in vaginal delivery. Avoid ergometry. ICU monitoring postpartum and no routine screening. Focus on risk identification plus early diagnosis. So that is what is the take home message from this particular article. Okay.